over here. So actually,
Hello.
I was expecting two previous speakers to be talking on topography guided LASIK, and I was wanting to provide a kind of balanced view about this entire so much talk around contour guided LASIK and really what works and what doesn't work. So since we haven't had the introduction, I'll quickly run you all through a topo guided laser ablation. The advantage, the obvious advantage which a topography guided laser provides over wavefront guided lasers is that the data captured is not limited by the pupil. It's not a dynamic measurements because the pupil is not involved. It's a static measurement over the cornea. I think Dr. Rajan is also trying to connect, I think.
Yeah, I would request the other speakers and audience to please mute.
Yeah.
You have a video. Request everyone to have the video and the audio off. That will give better bandwidth.
Can I
go ahead, Shreyas?
Yeah, thank you, sir. So, and then there are a lot of measurement points that can be captured, not just from the center, but from the peripheral cornea as well. We have better peripheral data, and it's entirely cornea based, which is where most of the higher order aberrations are present. So the early excitement about topography guided LASIK came from this paper from Doyle Stuttling, who did a study for the FDA group, and they showed that almost 40% of patients gained one or more lines, which is a phenomenal result when you look at any kind of LASIK procedure. But one thing we had to remember that this topo guided LASIK, which they did, was not just on all eyes. They had very, very strict criteria. When the refraction, that is the difference between the refraction axis and the measured axis on the topography cylinder, was more than 5 degrees, then they would not take it even the cylinders were high. Essentially, if you had 2 or more diopters of cylinder, even a 5-degree difference, they would discard that patient and go ahead with wavefront optimized. If it was less than 2 diopter, they went only up to 10 degree. But unfortunately, in reality, when we see patients who undergo a subjective refraction and then we look at the axis on our topography, a 5 to 10 degree difference is actually very, very common. And we get a lot of patients where the difference is much more than that. So what do you do about those patients? Do you generally discard contour altogether or discard any form of topography guided treatment altogether and just stick to wavefront optimized? Then why are we talking so much about this treatment if this is all the difference that we are going to allow? So essentially, let me show you what we are doing here. Contour basically does is a wavefront optimized profile. On top of that, it looks at the corneal higher order aberrations which are treated, and a combination is what you get. So essentially, you saw a 36 micron for wavefront optimized, 6 microns essentially for the higher order aberrations, even in a relatively normal cornea. And this was the 42 for the entire ablation, giving a better, smoother corneal profile. A lot of talk came in after this paper was published by Canelopoulos, where he said everything, whether it's uncorrected, best corrected, reliability, contrast sensitivity, everything was better in topo-guided LASIK when compared to SMILE. He said that he would go ahead with what he called TMR, that is entirely go ahead with the refraction given by the topolyzer or the topography instrument used in Contura, which is a Placido-based device. But unfortunately, this results which he showed was not mirrored by a number of centers which subsequently studied this, including our own. Let me illustrate that with a case example. When the early excitement of Contura came in, we did a contralateralized study comparing SMILE and topography guided LASIK, and I'll show you the results of this for this particular patient. You can see here, fairly high cylinder in both eyes, 1.75 and 2.75 in either eye, and we subjected the patient to a randomized control trial where the right eye was SMILE and the left eye was the TMR-based Contura LASIK. So in the TMR, we discard whatever the subjective refraction is. We are correcting the full entire cylinder, which is measured by the topolyzer, and go ahead with the treatment. If you look at the postoperative period, the right eye, which was treated with SMILE, the topography showed 1.3 diopters of cylinder almost. Whereas if you look at the Contura eye, the topography was beautiful, absolutely symmetric, and the astigmatism topo cylinder was only 0.1. But if you look at the refraction, to our surprise, the SMILE eye was 6.6 unaided, and the Contura eye had a 0.75 diopter cylinder. Essentially, from a 180, it went to a 90. So essentially, there was a overcorrection, and which resulted in a residual error and flipping of axis. So even though the topography was much, much better in TMR Contura, the patient was subjectively less happy. And that's really what we are looking at. And subsequently, other papers also came which showed that treating entirely based on the TMR did not make sense, and it gave rise to inferior refractive and visual outcomes than the manifest refraction itself. This is essentially because the final cylindrical correction, I'll just take a minute more. The components are the anterior corneal astigmatism, your higher order aberrations, especially the coma contributing to astigmatism, then the posterior corneal astigmatism, internal corneal astigmatism. The internal astigmatism. So there are various components to which are each of which are contributing to your final correction. So just even the patient's higher order aberrations, if the coma is can actually present as a cylinder in your subjective refraction. If it is the same axis as your anterior corneal cylinder, then the refraction cylinder will actually be higher. If it is in the opposite axis, the refraction cylinder will be lower. So it's time we moved on from just treating on the anterior cornea and use some software like this, which actually integrated the entire components. Forcides is one such example, which we're using routinely now, where essentially you take in the subjective refraction, you're taking in the anterior corneal astigmatism and the higher order aberrations from the topolizer. You take the posterior corneal astigmatism from the pentacam, and then you do a vector analysis of each of these, where you treat the higher profiles, the taluses, each of the vectors are taken into account, and then you have a final resultant vector, which is finally treated. That particular patient, which I showed you, if we entered the data retrospectively, it gave recommended a correction which was much closer to subjective refraction, essentially because the posterior corneal astigmatism was negating the increase which was being shown by the anterior cornea on the topolizer. So we have an ongoing study now where we are looking at a contralateralized study comparing Forcides with Contura, and so far we are seeing superior and consistent results when we are using this software. So in conclusion, analyze the measured versus subjective refraction that you have. If you're unable to get a proper rationale to why there is a higher astigmatism on measured, better to stick to Wavefront optimized. We must remember what the patient sees at the end of the day is the uncorrected visual acuity and not how regular or how green the topography is. Thank you so much for your